My name is Dr. Jason Wasfy. I am an associate editor at JACC. I'm an associate professor at Harvard Medical School and a cardiologist at Mass General Brigham. And I am delighted to be here with Dr. Bobby Yeh, who is professor of medicine at Harvard Medical School and the director of the Smith Center for Outcomes Research at the Beth Israel Deaconess Medical Center. And I'm also here with Dr. Katrina Dangas, who is a research fellow at the Smith Center. And I am delighted to report that she is about to start her internal medicine residency at the Massachusetts General Hospital. So welcome. Thank you for joining us.
Thanks for having us.
Thanks for having us.
So we are delighted to publish your article, Outpatient Migration of Cardiovascular Procedures in the United States. And there was a lot of enthusiasm on our editorial board for this particular piece because we thought it was informative and well written. But most of all, we thought this information is just really important for cardiology practice. So I guess maybe just tell us, what do you think are the most important things for cardiologists of all types and all settings to understand about ambulatory surgical centers and office-based laboratories?
Yeah, thank you so much for that wonderful question. So I think ambulatory surgery centers and office-based labs have been around for decades, but over the last decade or so, we see an increasing number of cardiovascular procedures migrating into these settings. And as they become more common non-hospital outpatient-based procedural settings for cardiovascular procedures, it's really important for cardiologists to understand the context in which that allowed this procedural migration into ASCs and OBLs, particularly policy reform and also the improved procedural safety of these procedures. And then also some of the key issues that are plaguing ASCs and OBLs right now, which include things such as overall market trends, as well as care quality and access to care, and also some of the regulatory considerations around ASCs, which are things we sought to explore in our article.
And so this ends up being, even for those of us who have backgrounds in sort of academic health policy, this is pretty wonky. This is pretty difficult, to understand a lot of the transactions here. But as a general matter, I think it's fair to say that for most procedures performed in OBLs or ASCs, the aggregate cost, technical fees plus physician fees paid by the payer, the insurance company, is overall lower. Is that correct?
Yeah, that's correct.
And so you can see why the payers might be excited about this. So there are complex issues where procedures in inpatient hospitals, and inpatient hospitals have all sorts of facilities that outpatient facilities don't have. They have code teams, they have trauma centers, they have special pathogen units that are not, they lose money, but those funds are recouped by margin on these types of procedures. Do you see a risk with this trend for inpatient hospitals, that as a lot of these lucrative procedures sort of out-migrate to outpatient settings, that the subsidy mechanisms that finance under-reimbursed services may be stressed?
Let me just maybe take a step back and think about the context in which all this is happening. I think people know that there are procedures that are performed in the outpatient setting away from hospitals. I think for many years now, peripheral vascular interventions have been performed in office-based laboratories, not tied to freestanding hospitals. And over the years, a number of procedures have become more safe. And as that safety is enhanced, you've seen these procedures move to sort of less and less, I think, hospital-based care. Even at hospitals themselves, what we used to have an overnight stay for every PCI. Now, PCIs are discharged the same day for the most part. AFib ablation procedures, they've gotten safer with new technologies. Those are, consideration for those moving into the outpatient setting. So a number of these forces that have happened have been both the desire to decrease costs from the payer standpoint, most notably CMS, but also coinciding with an enhanced safety of these procedures, which have allowed this. And so there is a strong trend to be able to move patients to the outpatient setting for these lower risk procedures and maybe meeting them where they are in their communities while at the same time reducing costs. One can imagine there are risks to doing that. These are procedures that are done in hospitals for a reason. The reason primarily being safety. So all of those things that pay for the full, safety, the availability of cardiac surgery in case a complication were to happen, general anesthesia, all of these things that make procedures more expensive are also there to make them potentially more safe. So that's where I think the critical question comes in is, are they safe enough? What types of procedures ought to be done at potentially lower cost, potentially more convenient for patients? And where's the trade-off? We're beginning to sacrifice safety in a way that's not good for patient care.
So I guess, and you have a really nice part of your paper that addresses sort of the quality agenda, sort of to understand, what needs to be measured and what needs to be sorted out going forward to understanding, if this is a good thing and how to implement it. But let me push on this a little bit, because this is going to get at clinical events that are relatively rare, but really bad when they happen. And that's a really squishy space. That's a difficult space to study, and because you really require large data sets. It's almost like stent thrombosis in clinical trials. It's really bad when it happens, but it's relatively rare. So you really have to aggregate very large data sets. It's important to know the difference, but it's a small effect estimate. There's also an issue of selection bias, presumably. As this gets out into the real world, as you're supposed to do the simpler cases in these settings. So to the extent that they have fewer complications, if we observe that in observational data, doesn't necessarily mean, it may just refer to case selection as opposed to the appropriateness of the care setting. So I would love your expertise and thoughts, because I know you've thought a lot about this, about how to sort through some of these issues going forward in terms of assessing the safety of performing procedures in these settings.
It's a really important question. And it is a question that is hard to answer with the data, but certainly hard to answer the question when you don't have any data. And that's really one of the things that we've tried to emphasize in this article. And let me say that, you started out by saying that this was sort of a wonky topic. It is. It's very esoteric. There are policies around this that most cardiologists don't know about. I would say that we were, myself, not familiar with many of the policies. And Katrina spent the better part of this last year diving headfirst into figuring out what was the specific policy in different states with payers, with accreditation for hospitals and other things. And she really did a fantastic job putting this together to help us give a better understanding to this and what are the policies and what are the sort of pressures around it. Now, one of the conclusions that she and we came to was that we needed better data. And there are efforts to create stronger registries, but right now the typical registries that we use to understand procedural safety and effectiveness typically do not include procedures that are performed in these OBLs or ASCs. That's really important. So one of our big conclusions is we ought to invest in creating those registries, or at least integrating those institutions into the existing registries. The second one is really important, which is, what you called selection bias, we might say, is appropriate selection of patients. Right. That's clinicians doing their job, which is finding the low-risk patients in these settings. And we had an early peek at that with some research that Katrina led. So Katrina, I'd love for you to talk about, the research and our interpretation of that research of the procedures done in outpatient settings.
Yeah, absolutely. So to echo your points, I think the current evidence that we have for cardiovascular procedures in ASCs and OBLs chiefly comes from small multi-center, single-center studies, and also claims-based databases, each with their own limitations, but both essential in different ways. So small multi-center studies are not nationally representative, while claims databases maybe lack some of the granularity to really robustly assess care quality. Nonetheless, they serve as important first looks in the absence of national registries, which is the state that we're in currently, or only having very limited data from national registries. So for example, for PCI, there aren't currently enough data coming from registries to be able to analyze some of the short-term safety of PCI and ASCs. So we chose to do an analysis using Medicare claims data because this is a nationally representative database. And what we found that, first of all, the number of PCI and ASCs amongst Medicare patients still makes up a very small percentage of the total number of outpatient PCIs happening in Medicare patients. Nonetheless, these seem to be happening in patients who are more socially vulnerable, which is an interesting finding of our analysis. In terms of the adverse events that we looked at, we were interested to see low rates of adverse events following PCI at 30 days in both ASCs and hospital outpatient departments. But as you really astutely pointed out, Dr. Wasfy, we can't definitively determine whether we would think that this represents sound patient selection, and we don't know the extent to which this represents a risk stratified comparison.
Yeah, no, that makes sense. And so I guess I have a role in the NCR, so I probably should know the answer to this question, but it sounds like individuals who have PCIs in this settings do not end up in the CAF PCI clinical registry. I see. So that, yeah, that is a major challenge to using, it's essentially impossible to use registry data. And so you used claims, that you're using claims data, and presumably because these are done in the outpatient setting, you have to merge Part A and Part B Medicare claims to even get information about comparisons. Is that right?
Exactly right. Exactly right. You needed to have the provider files in order to find all the procedures that are done. So some merger of the inpatient and outpatient. It was a complex undertaking that Katrina and our statistician Young tried to figure out exactly. It's not that straightforward to figure out which procedures actually are being performed at ASCs. It's a testament, again, to the data problem that we have, which are even identifying which patients are being treated in those settings for some procedures is challenging.
Recognizing, I mean, one huge takeaway that I have is around the data limitations here and the potential, you know, we're talking about selection bias and things like that, but it's even a more fundamental problem. There's no database that kind of has all these individuals aggregated in the same way. So that's an important takeaway. I mean, do you think that, I guess, would you say that, let's say somehow that problems get solved? You know, Katrina, I know you've kind of spent like a year working on this. You know, I'm struck by the extent to which state level policies differ on this, which leads into different organizations making different decisions in different states. Are there potential opportunities? I mean, again, if we solve the data problem, to use natural experiments to exploit the state by state policy differences as an instrument, say, to study the comparative effectiveness of performing procedures in different settings? I mean, again, with the data, if the data problem ever gets solved.
I think it depends on the question that you would want to answer. I think, for example, it would be appropriate to, for example, assess whether complete prohibition of ASCs, such as in the state of California, compared with a state where there are PCIs happening in ASCs, for example, like Texas, that's a possibility. Alternatively, you might seek to, which is an issue that has come up in other settings, which is the impact of certificate of needs laws on outcomes for procedures in ASCs. And there you could compare CON versus non-CON states.
Yeah,
potential.
One of the challenges right now is that, you know, what you really need is there to be a lot of exploitable variation to be able to do one of those. Right now, the variation is not that great. Even though we have different policies, there has not been like a wholesale movement of PCI to ASCs, for example, in even states that have very loose laws for ASC regulations, because I think, you know, for whatever reason, that migration is happening slowly. I think it's going to pick up over time. You know, peripheral vascular interventions moved a little bit more quickly. And so that might be an area where we could at least get a first look at it to see whether or not maybe states that had a lot of migration into these sort of ASC OBL settings really for the peripheral vascular procedures have different outcomes overall. But I think they still constitute, you know, a minority of them, such that the exploitable variation may not support like a really strong kind of natural experiment design. But in the future, should we see much more migration, I think there would be some opportunities for that. And those might be stronger, as you're implying, analytically for interpreting sort of causality of that safety of an outpatient procedure at an ASC or an OBL.
Yeah, so it sounds like much to do in terms of improving the data, thinking about methods for quality assessment. It's an agenda for years to come. Maybe let's close by just any advice to cardiologists in general practice about what they should be aware of or mindful of as this trend continues in the United States.
One important thing would be potentially thinking about asking the questions about whether this is, when you have a patient coming to you, whether they would be the right type of patient to have a procedure done in an ASC or not, and to follow the existing guidelines or guidance that does exist around patient selection, and also to think about educating themselves about this new procedural care setting that's likely to increase in its prominence in the cardiovascular care community.
Yeah, no, it sounds so.
There's so many stakeholders here for something like this. You know, you can think of patients as being an important stakeholder, obviously, and patients may want to know, you know, what's the environment like when I get a procedure done? I just had knee surgery down at MGH Waltham, and I gotta say it was a wonderful experience. You know, who's going to be doing my procedure if I get it in an ASC? What are the things that I have to be concerned about? Is it the same operator? Is it the exact same physician who's going to do it at both places? Physicians are a stakeholder here. What's the team around you when you do your procedure at an ASC or an OBL versus the team that you have when you're at a hospital? And then obviously the hospitals and the payers are enormous stakeholders here. I mean, I think if you're a hospital administrator, last thing you want to do is be caught flat-footed and have ASCs and OBLs popping up around you who are doing all of your lower risk procedures before you've had a chance to get in that game. And there are hospitals that are investing themselves, as you know, in ASCs. And that might be something that I think hospital administrators and people who are thinking about the delivery of healthcare ought to be thinking about. So I think that there's something to be thought about for basically everybody who's in the business of cardiovascular care delivery about how this trends, how these policies are going to affect their businesses, their practice, their healthcare that they acquire, and really glad to be able to work with Katrina and a whole host of others here to be able to put out what we think is a really informative article.
Yeah, we are delighted to publish it. Thank you also for not only for sending us the article, but also your time on this interview. Dr. Bobby Yeh, Director of the Smith Center for Outcomes Research, Beth Israel Deaconess Medical Center, Professor of Medicine at Harvard Medical School, and Dr. Katrina Dangas, who we are just delighted starting at Mass General internal medicine residency in a couple of weeks. Thanks so much for the time.